Okay.
Okay, just, are you ready, Dr. Tom?
Yes.
Okay, just give me 1 minute.
Okay.
Okay. Hello,
Do
everyone.
you want?
Yes, Doctor. I'm Dr. Mahmoud Migdadi from Jordan Breast Cancer Program. I'm honored to welcome all of you to this session. I also want to say thank you for the great effort that you put in all your positions to support the women's health. Today, we will have the second session of the Jordan Breast Cancer Program Introductory Series to the Multidisciplinary Conference 2022. The session will be about using ultrasound to stage breast cancer when MRI is not available. Please allow me to welcome our great speaker, Dr. Tom Stavros. Dr. Stavros is a fellow at the American College of Radiology, a fellow of the Society of Radiologists in Ultrasound, and an honorary fellow of the Royal Australian and the New Zealand College of Radiology. Dr. Stavros has authored the textbook Breast Ultrasound and has lectured and taught extensively on breast ultrasound around the world. Dr. Stavros is a board-certified radiologist who had a special interest in ultrasound breast imaging for more than 40 years. Dr. Tom, you have the mic, and Dr. Tom, you have the mic, and you can start at any time.
Okay. Thank you. Good evening for you. It's midday here in São Paulo, Brazil. And today I'm going to talk about using ultrasound for staging breast cancer. And what I'm not going to talk about is memorizing the TNM staging system. In fact, this is more about the general principles of determining size and extent and actually defining the difference between size and extent, because they are different things. And, we're going to talk more about how breast cancer grows and spreads inside the breast and how we can best determine how to treat it best surgically. And really, when I do talk about the TNM system, I'm going to talk more about its weaknesses and where it isn't serving us as well as it could. And I'm also going to talk about the problem staging that we have with the small 1-by-1 histology slides that the pathologists use, that it would be much better if they used large section or at least mega cassettes. Now, the TNM system has two particular problems. Problem number one is it doesn't deal adequately with multifocal and multicentric disease. And we know from many studies now that a majority of breast cancers are multifocal. So let's go through two examples of where TNM doesn't get it right. Example one, let's say that we have a multicentric cancer with 8 foci in 3 different quadrants. And the largest of these 8 foci has a maximum diameter of 1.2 centimeters. In the TNM system, they would call this a 1.2 centimeter cancer, which is way, way underestimating its true extent. Example two, we have 30 foci in 3 quadrants, each with only a 0.5 centimeter maximum diameter. In the TNM system, this would be considered a 0.5 centimeter lesion. And if the woman died, they would say she died of a 0.5 centimeter cancer. Well, that's not at all true. She's got 3 quadrants full of cancer, but the TNM system doesn't deal with multifocal disease adequately. The other place the TNM system falls down is with extensive so-called in situ or DCIS components. So let's take an example there of a 7mm grade 3 DCIS with 7 centimeters of lobar distributed casting calcifications or linear branching calcifications. But there's also a 0.7 centimeter grade 2 invasive ductal cancer. In the TNM system, that's a 0.7 centimeter cancer. Well, what we're going to show you, and this is Laszlo Shabar's theory, is that many of these DCISs are actually stem cell invasive duct forming cancers. So really the question you have to ask yourself, and in these particular instances that I've shown above, does the TNM system accurately represent the tumor load? And the answer clearly is no, it does not. What is important in survival and treatment? The tumor load. So I was disappointed when the new TNM system came out a couple of years ago and it did not address some of these deficiencies. Some of these deficiencies are falsely used to disparage MRI as overdiagnosing cancer when that is not true. In fact, it's the TNM system that's underdiagnosing cancer. Now,
Dr.
Even
Tom,
though we're going to talk, yes.
sorry for the interruption, but you can start your video right now.
Oh, I can? Okay. All right. Very
Yeah,
good.
that's it. Yes, doctor, you can proceed right now. Yeah, that's great.
All right. So even though we're going to talk about ultrasound for staging today, in the United States, for local regional staging, MR, contrast enhanced MR is considered the gold standard. And for systemic staging, PET-CT is considered the gold standard. But the truth of the matter is the correct MR equipment and sequences are not always available. MR is actually quite a bit more operator dependent than people realize. In some patients, MR is contraindicated, and especially in the United States, some insurance companies won't pay for it, even though we prefer it. And even after MR, second look ultrasound is often necessary. And MR is not a great way to do biopsy. So if we do find something on MR that suggests it's more extensive than we originally thought, I usually take them back and do a second look ultrasound. I try to do the biopsy under ultrasound guidance on second look ultrasound. And the truth of the matter is almost all the patients who get MR will have undergone ultrasound first. And during that first ultrasound is our best opportunity to actually correctly stage it. So I would say that anytime you see a lesion that's BI-RADS 4 or 5 and you intend to do an ultrasound guided core biopsy, that's an ideal time to do a whole breast ultrasound and look at all the regional lymph nodes of the breast at the same time. Now, whenever we do a core biopsy under ultrasound guidance or a vacuum biopsy, we want to do a concordance discordance assessment between the histology and the imaging features. And of course, we do that for the main diagnosis. Is it benign or malignant? What type of cancer is it? But we should also do a concordance discordance assessment for the size and extent of the disease, for the distribution, and for the tumor heterogeneity. And so those are the things that we're going to be talking about today. Now, size is a problematic description because the way we use it in TNM, it means the quote unquote maximum diameter of the lesion. Well, if the lesion is a circumscribed lesion, that's pretty easy. If it's a spiculated lesion, it gets a little more difficult because do you include the spicules or not? If it's DCIS and unifocal, then that's pretty easy. But if it's multifocal, the size of the largest component, which is what TNM takes into account, the maximum diameter of the index lesion, is not the whole story because there may be 20 other foci that together have more volume and more surface area, which is probably more important even than volume, than the index lesion. And so size really is not an adequate term for defining the stage of a lesion. Now, I want to get into something that is a Laszlo Tovar theory, and he divides cancers into AAB, DAB, and diffuse cancers, which includes some DABs and invasive lobular cancer, but AAB stands for Asner adenocarcinoma of the breast. These are adenocarcinomas that arise from the acini within the TDLU. They might be invasive or they might be in situ. They can be unifocal, multifocal, or diffuse. And when it is in situ, it's not really ductal carcinoma in situ because it's not starting in the duct, it's starting in an acinus. So it could be called carcinoma in situ, CIS, but it's improper to call it DCIS because it's not arising in the ducts. These generally have better prognosis when unifocal. Now, DAB is ductal adenocarcinoma of the breast. It does arise from the ducts. It can be DCIS, but it can also be an invasive duct-forming cancer. We know that some of these are actually stem cell cancers that have undergone epithelial to mesenchymal transformation. And there are many tests that we can do to confirm that these are stem cells, including CD44 plus, CD24 minus, ALH. There are various other things we can do to prove that they're in fact stem cell cancers and not really in situ. Now, let's just talk about the difference between DAB and CAB. I'm showing you here a picture of breast anatomy. This is normal breast anatomy. So there's the anterior mammary fascia outlined by the white line. In front of that is the subcutaneous fat, and behind that is the mammary zone. Now, in the periphery of the mammary zone is where most of the TDLUs lie. So you can see they're most numerous anteriorly. These little gray circles are each TDLUs, and they're less numerous posteriorly, but they're not very numerous in the center of the lobe, which is where the ducts lie. So these AABs, adenocarcinomas of the breast, that arise in the TDLUs, we usually detect them fairly early because they abut or are adjacent to fat, and they cause changes in the fat fairly early. So here's an AAB that's arising at the intersection of the subcutaneous fat and the mammary zone. Here's another one, and another one. And so these appear as architectural distortions or posterior tenting or various other mammographic features, but we tend to find them early and small. Now, they may be multifocal, but we can see these at a relatively early stage. The DABs, which arise from the ducts that are in the center of the lobe, can you see my cursor, by the way, my arrow? The DABs arise from the ducts, and because they're in the center of the lobe, they do not present early. They present late, and they usually present with linear branching calcifications. So we tend to have an entire lobe involved when we find them. And we can see that this late detection means that they have a worse survival rate. So these are TAVR data, and you can see that the DAB survival rates are much lower out at past 15 years than are the AABs. So most of the lives that we save from mammography are of AABs that we detect early. We don't impact the survival much in DABs because we just don't detect them early. So when a patient comes in and says, "Doctor, how big is my tumor?" we talk about size, but what is size? Well, in TNM, size is the maximum diameter of the index lesion if there's multifocal disease or a mixture of invasive and DCIS. But extent is more important in terms of treatment and prognosis. And the extent may not be the same as size. The extent is often much larger. And so what I'm going to show you during this talk is many, many, many cases where size is different from extent, and extent is much larger than size. And so rather than using the term size, I think maximum diameter and extent are probably two better terms for using that. So if there's multifocal disease, the extent is going to be the outside to outside diameter between the two farthest apart foci of invasion. If it's a mixture of AAB and DAB, invasive and DCIS, the extent is going to include the maximum diameter of the invasive lesion, which is the size, but it's also going to include all the DCIS components. So what really matters is the tumor load, and extent is a better marker of tumor load than is size. And in fact, one advantage of MR is that it can give us volume or surface area. That's a little hard to get from ultrasound, but volume and surface area probably are better estimates of the tumor load than our diameters. So let's just look at different kinds of cancers. This would be a circumscribed cancer. This could be a mucinous cancer or an encapsulated papillary carcinoma or grade 3 triple negative. They look like this. This would be an invasive cancer. This would be more like a luminal A or luminal B cancer that's spiculated, that has a thick echogenic rim around it, an ultrasound. And on the third, on the right here, we have DCIS. That's a combination of AABs and DABs. So we've got 4 different acini involved. Those are 4 AABs connected by DAB components. So the diameter of the circumscribed lesion is very easy to figure out. We can just find the maximum diameter, and it's a very sharp border, a very circumscribed border. It's easy to measure. The invasive lesion with a thick echogenic rim, it's a little more difficult because do we include the thick echogenic rim or not? We'll talk more about that. And again, according to TNM, the largest TDLU, the largest AAB is going to be the size, but in fact, the extent is going to be the outside-to-outside dimension between the farthest apart AAB components in that case. So how big is the lesion? Well, it depends on whether we're dealing with pure in situ or invasive, whether we're unifocal or multifocal. So I'm showing a unifocal AAB. So that's a single enlarged TDLU filled with carcinoma in situ. This is multifocal carcinoma in situ AAB. This on the right is a mixture of DAB, ducts filled with tumor, as well as multiple acini filled with tumor. This is a unifocal invasive cancer, multifocal invasive cancer, and diffuse invasive cancer with lots of tiny foci. This, by the way, is not unusual in invasive lobular or HER2 type cancers. So when we see this, how big is my lesion in a mixed AAB and DAB lesion, for purposes of TNM, the maximum diameter of the lesion plus its thick echogenic rim is the size, but the extent includes all the DCIS components. If it's multifocal in TNM, the size is the maximum diameter of the invasive lesion with its thick echogenic rim, but the extent is the outside to outside dimension between the two farthest apart foci. And if we have a mixture of DAB and AAB, the largest diameter according to TNM is the size, but the extent you can see is quite a bit larger. And so what I'm showing you over and over in these drawings is that size and extent are different. The extent includes a larger tumor burden than the size. And in this respect, TNM doesn't do justice to the lesion and doesn't help us treat the patient as well as we might. And I was disappointed that the news version of TNM again does not really take imaging into account the way it should. It's still too clinically based, and it would do a much better job if we're imaging based. Well, when we're assessing concordance, discordance, we have to talk about heterogeneity. So you can see multifocal cancers, one circumscribed and one spiculated. Or you can see a mixture of AAB and DAB. Or you can see a mixture of invasive and DAB, or multifocal invasive or diffuse invasive. So when we have a circumscribed grade 3 invasive ductal cancer like this, triple negative, you can see that on the pathology, it's very easy to find the edge, and it's very easy to measure the maximum diameter. On imaging, the same thing. This is a triple negative, grade 3 invasive ductal cancer, very sharply circumscribed, very easy to determine the maximum diameter. And in this particular case, size equals extent. So in circumscribed cancer, size and extent are the same if it's unifocal. Now, this is a little different. This is an invasive lesion that's spiculated. And in this case, here's a case where I think the ACR ultrasound BI-RADS is not quite right, because the ultrasound BI-RADS says you should only measure the hypoechoic central nidus as the size. And I'm going to show you on some histology slides that there's microscopic tumor in the thick echogenic rim in virtually every case. And so it's wrong to exclude that. The thick echogenic rim is part of the lesion. So in a speculated lesion, we have a decision to make. Are we just going to measure the hypoechoic central nidus corresponding to the dark purple thing? Or are we going to look at the entire thing, including the thick echogenic rim? So here's a case on ultrasound. This is the hypoechoic central nidus, quite a bit smaller than the hypoechoic central nidus plus the thick echogenic rim or speculations. And so we're going to talk more about that. And I'm going to tell you that the way that I measured on the right is more correct, even though ACR, this is, some of our problem is that our defining structures or our defining documents, like the TNM documents or ultrasound BI-RADS, are imperfect. And they're living, evolving things. They will get better over time, but we have to recognize where they're imperfect and adapt to get the best results for the patient. Now, we should not be surprised that the thick echogenic rim is important on the grayscale ultrasound image, because we know it's important on elastography. So here's a lesion with a hypoechoic central nidus and a thick echogenic rim. And if we do strain elastography, The area of stiffness does not correspond to the hypoechoic central nidus, but does in fact correspond to the hypoechoic central nidus and the thick echogenic rim. On shear wave elastography, which I'm showing on top here, the stiff part is actually the thick echogenic rim, not the hypoechoic central nidus. This exact same case, the rim enhancement that we see on the MR does not correspond to the hypoechoic central nidus, but doesn't correspond to the thick echogenic rim. And if we take an animal model of cancer and we inject latex rubber into the feeding arteries and draining veins, and then dissolve the cancer with acid, we can see where the neovessels lie. And the neovessels, where do they lie? In the thick echogenic rim, where it's stiff and where we have ring enhancement. So we have other evidence in imaging that we've chosen to ignore in BIREDS when we said that this hypoechoic part is the size of the lesion. Not true. The size of the lesion is the hypoechoic central nidus plus its thick echogenic rim. Now, how do I know that? Well, first of all, I divide every cancer into 3 zones. So the hypoechoic central nidus is what I consider the internal zone. The thick echogenic rim in an invasive cancer, or the thin pseudocapsule of compressed tissue in a benign fibroadenoma, are the boundary zone. And then you can see that we have hyperechoic radiating spicules shown by the yellow arrows in the peripheral zone. Now, what I will tell you is that I've looked at many 5x7 mega cassettes, and I did those instead of the 1x1 slides because I wanted to see what was in this boundary zone. And too many times the little 1x1 cover slide on the pathology slides only included the central nidus. Too many times those tiny little pathology slides don't tell us what's going on in the boundary zone. So I examined numerous cases of invasive cancers on 5x7 megacassettes where for sure I could see what was in the echogenic rim. So here's an invasive cancer that we looked at on a 5x7 megacassette. So within this white dotted rectangle is a little bit of internal zone and a lot of the echogenic rim. So this white line on the pathology corresponds to the border between the hypoechoic central nidus on the left and the boundary zone on the right. So the boundary zone here is the thick echogenic rim that lies between the white region of interest line and the aqua colored region of interest line. And that's in this area right here between the aqua line and the white line. Now, if I magnify this, we can see that these white circles are fat cells. And we can see that's what's lying within this echogenic rim are some tumor cells, which are these large cells, some lymphocytes and macrophages, which are the smaller purple cells, some desmoplasia, which is the pink stuff, and some neovessels. But the important thing is every single case of these thick echogenic rims that I looked at contain microscopic tumor. There is microscopic tumor within the echogenic rim, and for purposes of staging, ACR, Ultrasound, BIREDS got it wrong. They said the echogenic rim is not part of the lesion. That's absolutely not correct. It is part of the lesion because there's always microscopic tumor in the thick echogenic rim. Now I want to go back to this case because it shows these thin hyperechoic spicules in the peripheral zone. Many times those do not have any tumor cells in them. That's just bland desmoplasia, bland fibroelastosis. So boundary zone, yes. Microscopic tumor, virtually every case. Peripheral zone, not necessarily. Unless the spicules are thick and fuzzy, they probably are sterile and do not have tumor cells within them. Laszlo Tabar is the one who talked me into doing these 5x7 mega cassettes, and I think it was very valuable. It taught me a lot, and I think it'll be useful for you to know that. Now, Again, internal zone definitely has tumor within it. Boundary zone almost always has tumor within it. And peripheral zone may just be sterile fibroelastosis. So for purposes of staging, you should include the thick echogenic rim or the boundary zone in the measurement of the lesion in terms of maximum diameter. Now, here I have a case that's a mixture of an invasive AAB, adenocarcinoma of the breast, and a DAB. So this is the DAB component shown by the white bracket. That's a grade 3 DCIS component growing up the duct toward the nipple, very close to the nipple, but not quite reaching it. The taller thing on the right, shown by the aqua brackets, is the AAB. That's an adenocarcinoma of the breast. It's taller than wide. It has angular margins and a thick echogenic rim. So the maximum diameter of this lesion, according to TNM, is this white line. That's the size. But the extent includes the DAB component. So you can see, if I compare the white line and the yellow line, size is not equal to extent. Extent is greater than size, and that's almost always the case. Now, how do we know what's the invasive part, the AAB part, and the DAB part? Well, we have strong mass findings that are signs of invasion that include speculation, angles on the margins, and acoustic shadowing. And we have non-mass findings, which correspond exactly to the non-mass enhancement on MR that include enlarged ducts, duct extension branch pattern, microcalcifications or microlobulations. And in ideal cases, we'll find these microcalcifications inside of enlarged ducts or microlobulations. So the DCIS parts correspond to the non-mass findings. The invasive parts correspond to the strong mass findings. And then we have some non-specific things like hypoechogenicity and taller and wide that can occur in either. So the strong mass findings are important in determining the maximum diameter of the index invasive lesion. The non-mass findings are useful in determining extent whenever there's a lesion that has mixed DCIS and invasive components or pure DCIS components. So here's an invasive lesion, invasive AAB, and you can see there are lots of enlarged ducts around it. So there are innumerable enlarged ducts up at 10 o'clock position relative to the invasive lesion, at 8 o'clock relative to the invasion lesion, and between 2 and 3 o'clock along the right side. So in this particular case, the size is going to include just the maximum diameter of the invasive part of the lesion, but the extent is going to include the two farthest apart components of the lesion that might be pure DCIS or it might be between DCIS and invasive part. But if you want to cure this, you're going to have to get both parts, and that's where the staging comes in. I mean, if you want a surgical cure, you have to know the extent of disease, not just the size. The size of this lesion is going to be irrelevant to whether you get positive margins or not. All right, so here's a case in real life. There's an invasive cancer with spicules, hypoechoic spicules surrounded by fibrous tissue, the index lesion, and then over at about 10 o'clock position relative to the index lesion is a secondary satellite invasive lesion with hypoechoic spicules along its left side. So, and then we've got an enlarged duct extending toward the nipple and a couple of enlarged ducts extending away from the nipple. So the maximum diameter, according to TNM, is just this pink arrow, the maximum diameter of the index invasive lesion. But the extent of disease here is going to go from the outside, the left side of the satellite lesion to the farthest component of the DCIS component or DAB component that's growing up the duct toward the nipple. So you can see that if you compare the size of the pink and the yellow arrows, there's a big, big difference in this case between size and extent. So if we look at a spiculated lesion and we properly measure it to include the echogenic rim in a unifocal invasive luminal A or B grade 1 or grade 2 invasive cancer, the size will equal the extent. And this is very typical for luminal A cancers, grade 1 and grade 2 luminal A. In a grade 3 invasive AEB, like a triple negative, size equals extent again. It's not difficult. Now, if we have multifocal disease, size will not equal extent. The size will be the maximum diameter of the index lesion, including its thick echogenic rim, but the extent is going to be the outside to outside distance between the two foci. Now, in terms of surgery, how far apart these is can make a difference, because in general, if this extent is more than 5 centimeters, they're going to say the patient needs a mastectomy. But say the largest lesion on the left is 1 centimeter and the one on the right is 6 millimeters, and they're 8 centimeters apart, the surgeon might be able to do 2 small lumpectomies rather than a mastectomy. But it's important to recognize that size and extent are different here. And I, some people measure inside to inside. I don't think that's correct. Some people measure middle to middle. I don't think that's the best way to measure it. In terms of guiding your surgeon, I think outside to outside is the best way to measure these multifocal lesions in terms of extent. So in real life, index lesion on the left, satellite lesion on the right. Size is the white dotted line. The extent is the yellow dotted line. Big difference. Again, multifocal invasive lesions with thick echogenic rims. So we're going to include the thick echogenic rims. The index lesion is on the right. So in terms of TNM, the maximum diameter is the white dotted line with arrowheads, but the extent is the yellow line. Big difference. Multifocal disease again, they're almost equal in size here. Slightly larger on the right, both have thick echogenic rims. So the maximum diameter is going to include the echogenic rim. Now notice that the hypococcentral is larger on the right, but the thick echogenic rim is larger on the left. Remember, the thick echogenic rim has microscopic disease. So in this particular case, I'm going to measure the maximum diameter on the left one to include the thick echogenic rim, and the extent is going to be the yellow area. Big difference between size and extent. This is getting more complicated. Now we've got 3 foci. Again, if a surgeon just did a wide excision and these multifocal lesions were not connected by DAB bridges, you could falsely get a negative margin there. But if I go back, you can see that the size of this lesion is on the left, and the extent is much, much different. We've got 3 foci now that are separated by so much. I had to do an extended field of view. This is 8 or 10 centimeters outside to outside diameter there. Again, index lesion on the left, satellite lesion on the right. A size, extent, grossly different. Multifocal lesion, size, extent, markedly different. Size, extent, markedly different. Size, extent, slightly different. This one is probably easier for the surgeon because, he can pretty much do a 1 centimeter margin and get all of this pretty easily because they're stacked. This is a very typical appearance for tubular cancers. They tend to be stacked on top of each other. This is usually going to be a luminal A grade 1, and this stacked appearance with one on top of another is very typical of tubular carcinoma. Here we've got 3 foci, big difference between the size and extent. And here we've got at least 4 foci with some DCIS components between them. Huge difference between the size and extent. Now, what I want you to notice is that I'm using a lot of extended field of view to demonstrate this. Or another option is split screen fused images. So here, the outside to outside dimension is too big to fit on a 5 centimeter or a 38 millimeter ultrasound probe. So I'm going to have to use logic view or panorama or seascape, or depending on what machine, whatever your machine calls it, I'm going to have to use some form of extended field of view, or I'm going to have to put together split screen mirror image scans, which is what I did in this case. But again, huge difference between the size and the extent. Now, I'm going to show you some examples of combined DCIS invasive lesions, where again, size and extent are going to be markedly different because the extent is going to include all the DCIS components as well as the invasive component. So here's a case. I've got a cancer arising in a TDLU. The index lesion is on the left. But if I draw in what I see a distal duct with 4 enlarged TDLUs on it. So the index lesion, according to TNM, is going to be lesion number 1. So that's going to be the size, what I'm showing with the white dotted arrow with the arrowheads. But the extent is going to include all the DCIS components, the DAB component in addition to the AAB components. So 1, 2, 3, and 4 could either be invasive cancer or DCIS components. I don't know for sure. All I know is I got 4 enlarged TDLUs that have AABs that could be invasive or DCIS, but I know that I have DCIS components bridging between them. So I know I have a combination, multifocal AAB plus DAB. And again, the extent has to include all the DAB components, not just the index AAB component. Now, we have to remember that the DCIS bridges may not be demonstrable for several reasons. You can get multifocal AABs that are in situ or invasive that have never been connected by DCIS or DAB components. You could get multifocal AABs that were at one time connected by DCIS components, but the DCIS components necrosed and went away. And that's pretty typical for micropapillary grade 3 DCIS. Another thing is that micropapillary can seed. So it doesn't have to grow continuously. These cells can wash down the duct in the fluid and then attach somewhere else. So that's another possibility. But you have to be aware that you won't always be able to show DCIS components connecting multifocal AABs. Now, where does the invasion tend to occur? Most likely at the branch points of ducts or in cancerized TDLUs. So here's a multifocal AAB with 3 different TDLUs that are affected. The largest on the right, labeled number 1, is the index invasive component. And then we can see that there are multiple grossly enlarged ducts bridging between them. This is a very typical appearance of invasive papillary carcinoma. They tend to have very, very prominent DCIS bridges between them. And the most common places for invasion to occur are in the cancerized TDLUs or at branch points of the duct. But again, huge difference between the size, which is the maximum diameter of index TDLU number 1, and the outside dimension between TDLU number 3 and TDLU number 1. So again, if we have an invasive cancer with a thick echogenic rim, the size will include the thick echogenic rim, but the extent will include the DCIS components. So here are 4 different foci, and I can see that there are some bridges between them. So the size is the maximum diameter of the congealed 1 and 2 TDLUs, and the extent is the outside dimension between TDLU 4 and TDLU number 3. Here's another case that's pretty good because I've got a good histologic correlation. I've got an index lesion, AAB, on the left. And if I just did a wide excision there, I would leave 2 foci, number 2 and number 3. Now this actually has DCIS bridges between it. So the size is the maximum diameter of the index lesion on the left, and the extent is the outside dimension between TDLU number 1 and TDLU number 3. Here we only have a partial DCIS bridge, big index lesion on the left, partial DCIS bridges, satellite lesion on the right. Size obviously is going to be the maximum diameter of the circumscribed AAB on the left. And the extent is going to be the outside-to-outside dimension between the index lesion and the largest duct that I can see that extends to the right of the satellite lesion. Now, another case, 3 different TDLUs. I see a partial DCIS bridge on the right. I see complete DCIS bridge on the left. My maximum diameter is going to be the index maximum diameter. And the extent is going to be the outside dimension between AAB number 1 and AAB number 3. This has really extensive DCIS components. Again, big difference between the size and extent. The extent is going to include the DCIS components, which I'm showing in yellow. Same thing here. Multifocal disease, big DCIS bridges. Maximum diameter is going to be the maximum size of the index lesion plus its thick echogenic rim. But the extent is going to include all these DCIS components. Now, in terms of documenting this for your pathologist, you know, we probably rely too much on MR in the United States, because when you're in the room deciding on whether you're going to do an ultrasound corded biopsy, it's really easy to just extend your exam to include the whole breast, to try to find all the DCIS components, all the multifocal lesions, and then to plan mapping biopsies right at the original time of your original biopsy. Well, you know, stage the lesion as best you can with ultrasound, even before the MR. So here are 2 cases that have extensive DCIS components. And in these cases, the DCIS components are far more extensive than the index lesion. But this is going to result in a huge difference between size and extent. And if you want the cure, you know, people can say what they want about leaving DCIS components and whether radiation can handle it or not. I'll show you why I don't think that's a good strategy. This is another one of very extensive DCIS components. Again, I'm showing the invasive lesion in white, the enlarged ducts in left. And notice that in green, I put a normal sized duct. And why do I do that? I always like to see normal ducts, because in grade 2 and grade 3 DCIS, you know, you can have the ducts be enlarged 4, 6, 8, even 10 times normal size. You know, if I see ducts that are twice the size of normal ducts, you know, I may not be very aggressive about that. I may go ahead and let them go to MR, or let them just do surgery and see if the margins are positive. But if I have ducts that are 4 times normal size like these, I'm going to do a core biopsy on the index lesion. I'm going to do DVAB under ultrasound guidance on the farthest away DCIS component that I can see, and large duct that I can see. And then I can make a definitive diagnosis of grade 2 invasive ductal cancer with grade 2 DCIS or DAB X number of centimeters away. So again, in this particular case, huge difference between size and extent. Same here, huge difference between size and extent. Again, I can see some normal ducts here, and here, and here, and here. So we can see that these are somewhere in the 3 to 4 times normal size. So what am I going to do here? Well, I would probably do core biopsy on the index lesion. I might also core the satellite lesion, and I would do a DVAB over here as far right as I could go. And then I'd have the extent of the disease mapped out with ultrasound guided biopsies. But a huge difference between size and extent. Same here. Now the difference between the normal ducts here and the abnormal ducts is smaller. I can see several normal sized ducts on the far left side of the screen. I can see several normal sized ducts on the far right, and these ducts are only about twice normal size. Once we get down into that area where the ducts I'm thinking are abnormal are only twice normal size, I get a little more cautious. In this particular case, maybe I'm only going to core biopsy the index lesion, and maybe with these ducts only being twice the size of normal ducts, or you know, maybe not be. I'd be less aggressive. You know, when the ducts are 4 times normal, I'm going to be aggressive with the vacuum biopsy. When they're two times normal sized ducts, I'm going to be less aggressive, and I may sit back and wait for MR or just whether or not the margins are positive or not. This one is grossly enlarged ducts, big difference between size and extent. Again, grossly enlarged ducts. This is a classical HER2 appearance. Giant, wider than tall lesion, often with casting calcifications and really grossly enlarged ducts, often again containing casting calcifications. Now, one thing that can help you when you're looking for multifocal disease is we get what's called satisfaction with search. We see the index lesion, which is shown by the white arrow, and our eyes get so focused on it, we can't see the secondary and tertiary lesions. But if I do power Doppler vocal fremitus, where I put on power Doppler with a solid orange or yellow map at a PRF of 1000, and I have the patient hum in a deep voice, and I specifically say, don't hum up here, I want you to hum deep, way down here, because the lower frequency creates vibrations. But now I can see 1, 2, 3 foci, whereas in the original lesion, I really only noticed the original one. So it's much easier to find 3 black holes in a sea of yellow or a sea of orange than it is to find 2 subtle satellite lesions that are just subtly more gray than their surrounding tissue. And in this case, once I found them, then I can optimize my image to show them. And in this particular case, I don't need to biopsy all 3 of these. I'm going to do a core biopsy or vacuum of the lesion number 1 and a core biopsy or vacuum of lesion number 3. And I can just assume that 2 is the same. So I don't have to biopsy all 3. I biopsy the extreme ends of the lesion. But again, you can see here a huge difference between size and extent. And here I'm just showing that I would vacuum TDLU number 1, vacuum TDLU number 3, and then I could say, yes, there's multifocal invasive ductal cancer or multifocal DAB or some combination thereof. Now, when we have a lot of DAB that's cancerized lobules, again, the size and extent will be the same. We'll just include the maximum diameter of all the TDLUs and ducts that are involved. If we have diffuse disease with multiple small invasive lesions, like we often see with invasive lobular cancer, then there can be a huge difference because according to TNM, the size of the lesion is the maximum diameter of the largest of the multi or diffuse invasive lesions, but the outside to outside dimension is going to be more pertinent in terms of the prognosis and treatment. Now, this is an AAB. So this represents the enlarged TDLU, and it's enlarged extralobular terminal duct. And we can see the enlarged extraterminal lobular duct on the right, and the multiple enlarged acini. Bottom line is its long axis is parallel to the long axis to TDLU. Now, you can have multifocal AAB that's connected by DAB bridges, DCIS bridges, involving the ducts between the TDLUs, but you can also have multifocal AAB that does not have connecting DCIS bridges. It just arose simultaneously in 3 separate TDLUs. And the problem there is that a negative margin may not matter much. So here we have a big difference between size and extent. Again, here, size and extent markedly different. Size and extent different again. These are pure DCIS. This is the MR of that case. I think the ultrasound shows it as well as the MR in this particular case. But here I'm demonstrating that there doesn't have to be a connecting DCIS bridge between multifocal AAB that's in situ, carcinoma in situ. So if I did a wide excision here and got negative margins, I might be falsely reassured. Or the surgeon might be falsely reassured. But if I can see that there are multiple enlarged TDLUs and I can map out that it's multifocal disease, then the surgeon isn't going to be misled by a negative margin. Now, this can happen with both invasive lesions or in situ lesions. So on the left, I'm demonstrating multifocal in situ AAB or multifocal carcinoma in situ. And on the right, I'm showing multifocal invasive AABs, both which could have falsely negative margins. So here we're seeing a case like that. I've got stacked tubular carcinomas on the right and a tubular carcinoma on the left, or actually a AAB on the left. And if we do a wide excision and get negative margins, I may be falsely reassured from the pathology if I'm the surgeon. But if I properly biopsy this with the core biopsy and do a vacuum of this and say, yeah, I got multifocal cancer, at least 3 separate foci separated by such and such, and I do bracketing wires, I bracket this between wires for the surgeon, then we're not going to be falsely reassured by multifocal AABs that aren't connected by DAB bridges. Now, most of the time when we have multifocal disease, they're going to be homogeneous in terms of type of cancer. So if I have multifocal luminal A cancers, they're all going to be spiculated. But it is possible to get a triple negative or invasive papillary or mucinous carcinoma together with a grade 2 invasive ductal cancer or whatever. So you can get a mixture of circumscribed and spiculated. You get a mixture of AAB and DAB. You can get a mixture of invasive and DAB. And so you can have all sorts of mixtures of homogeneous and heterogeneous cancers. Now, here's why I believe that it's important that we detect these so-called DCIS components and multifocal disease. These are Tabar graphs. And what Laszlo does that nobody else does is he follows these things for 15, 20, 30 years. And so the blue line is what we get with unifocal Asner adenocarcinoma of the breast, invasive. 89% survival at 15 years or 14 years. We can see that when it's multifocal, it's about 13% lower survival at 14 years. And when it's DAB, some of which include these stem cell duct forming invasive cancers, it's down to 61%. Now, what you're going to see in a lot of the literature is somebody's going to look at 5 years and they're going to say, well, there was no significant difference in survival between multifocal and unifocal disease. And that what we don't see here is the 90% confidence intervals. But if I plotted the 90% confidence intervals, they would overlap at 5 years. But they definitely don't overlap out here. And so when people are making decisions about whether it's okay to leave additional foci of cancer or DCIS components of cancer, and they're looking at 5 years, they're not looking far enough out. That's not a wise decision to make. You need to look out beyond 10 years, out to 15 years where Laszlo looks, in order to really see that it does matter. It's not innocuous. Now, what about radiation? You know, people are saying, oh, it's okay to leave DCIS components. Radiation can handle it. Is that true? Well, these are the survival curves with and without radiation. And you can see that the survival curve is worse without radiation than it is with the radiation for the stellate lesions. But you can see that radiation doesn't completely bring this line up to where it should. So does radiation help a little? Yeah. But again, you know, again, if people are looking at 5 years or 3 years, you know, the 90% confidence interval are going to overlap. You got to get out here to 7 years before you can see that there's a big difference between DCIS components that are left behind and those that are removed. So you can't tell in those first 5 years. You got to get out to 7 years in this particular case. And yes, radiation helps, but it doesn't completely help. Now, you know, how do we know if there's extensive intraductal components? Well, we can look for pronounced non-mass findings. So very pronounced microlobulation, very long duct extensions, very extensive branch pattern. And these things tell us, especially if we can see normal ducts in the same field of view, and the ducts we're seeing are 4 times normal size or larger, 5 or 6 or 8 or 10 times normal size, we know that those are going to be DCIS components. So here's a markedly heavily microlobulated lesion, and on pathology, some of these microlobules have very sharp white lines around them and are oval shaped. These corresponds to ducts filled with comedo DCIS. Some are purple and are more ill-defined, and these are cancerized lobules. So in this particular case, we're seeing a mixture of enlarged ducts and cancerized lobules contributing to these microlobulations. Here we're seeing a very long duct extension. Yes, I could do a core biopsy of the index lesion and say, yep, that's grade 2 invasive ductal cancer. But if the surgeon went in and did a wide excision, there'd be a positive margin. And then if they did a resection of that margin, it would still be positive. And maybe now the surgeon might say, gee, this is too big for a lumpectomy. I have to convert this to a mastectomy. Better approach in my mind is to core biopsy the index lesion, vacuum biopsy the farthest away DCIS component, and then I could say definitively, this is a 2.5 centimeter grade 2 invasive ductal cancer, and 3.5 centimeters away is a grade 2 or grade 3 DCIS. This is really a 6 centimeter lesion, and a simple lumpectomy is not the optimal surgical procedure for this case. A segmentectomy or induction neoadjuvant therapy, and then a relook later. There's got to be approaches better than just a lumpectomy in this case. Or maybe we have to go straight to mastectomy. So there are multiple options, but if I only core biopsy the index lesion and I ignore the long DCIS component, I don't come up with the best diagnosis. Well, that's not the worst story, because the worst story is margin analysis is terrible. From the 1-by-1 slides that pathologists use, it's estimated that only, I think Lee Tucker did this study in Virginia, only 16% of the margin is actually assessed. That means there's an 84% chance that this positive margin could be missed. And in that case, the patient gets recurrent cancer 18 months later, really not recurrent, unrecognized, untreated disease would come back or become clinically evident 18 months later. So again, that's my argument for why we should map this out as best as possible at the initial scan. Now, this is a very extensive branch pattern. This was actually a benign papillary lesion, underwent secondary malignant degeneration, had lots of grade 2 DCIS components associated with it. Now, I like to even put the ultrasound probe on calcifications, even just clustered pleomorphic, or what Laszlo calls crushed stones calcifications. And here's the reason why. Here's a case where we've got crushed stone calcifications. I'm not even showing you the mammogram, but I could have done a stereo biopsy on this. And this is the DCIS part of the lesion. The solid mass is the invasive part of the lesion. So we can see that all the DCIS components where the calcifications are over on this left edge, and all the invasive part is on the right edge. So by looking at these calcs with ultrasound, I can properly diagnose invasive lesion that I might underdiagnose with stereo. We know that with stereo biopsy of calcs, we tend to underdiagnose invasion. I might just get pure DCIS on a stereo biopsy of the calcs, whereas doing an ultrasound core biopsy of the solid part of the lesion would give me the definitive diagnosis of invasive cancer with DCIS components. Now, these are split screen image scans of 12 o'clock location on the right breast and left breast. And we can see that I've got an enlarged duct with calcification, many times normal size. We can see that this one, I can see a normal duct there, and this one is probably 8 to 10 times normal size. And there's also too many ducts. So one of the signs of these DAB components is too many ducts. These are neoducts. They're actually completely invasive ducts forming that are far too numerous. So I can see that on the right side, I've got maybe a dozen ducts. And on the left side, I've got dozens and dozens of ducts. Now, when we get DCIS components, they can spread through the breast through native ducts. or they can spread through the breast by forming neoducts, which just shows up as heavy microlobulation, or too large and too numerous polymorphic ducts. By polymorphic, I mean that they vary in size, shape, and orientation. And we can get mixtures of spread through the native ducts and neoducts. In general, the spread through the native ducts is going to be closer to the nipple, and the neoducts are going to be farther from the nipple or more peripherally located. So here we can see that we've got some ducts that are enlarged without calcifications, some enlarged with calcifications, and some irregular masses that probably represent invasive components here. So in this particular case, we're going to have a huge difference between the size and extent of disease. This is an MR of diffuse ductal adenocarcinoma of the breast. And again, we can see a few normal ducts here. We can see here's one, here's one. Here's a branching duct. There's a normal one here. These ducts are 4 to 6 times normal size. Most of them don't contain calcifications, but they're too numerous. If we did split screen image with the other side, they'd be too numerous. But in this particular case, size and extent are same. Now, neoducts can cause architectural distortion. So most of the time when we see architectural distortion, we think radial scar or invasive lobular or stellate, invasive ductal cancer. But you can get DABs that radiate. So this is what was called pure grade 3 DCIS. Again, I think this is actually DAB and a stem cell duct forming invasive cancer, underdiagnosed as DAB by pathology, but you can see that they're radiating in this particular case, and same here. Well, these are calcs, and again, in general, mammography is going to be pretty good for solid grade 3 comedo DCIS, less good for micropapillary. So in this particular case, I see a lot of enlarged ducts with calcifications in the center of my field of view, but on the edges, I have many ducts that are enlarged without calcifications. The last thing we want to do in staging is check for critical structures being involved. In particular, we want to know if the nipple's involved or if the skin and subcutaneous tissues are involved. With ultrasound, it's very difficult to know about chest wall, because when a patient's on her back, everything falls against the chest. You almost have to have the patient sit up and lean forward, but even then it's difficult because of acoustic shadowing. So with ultrasound, we can assess whether the nipple's involved or whether the skin and subcutaneous tissues are involved, but not necessarily are we as good as MR at telling whether there's chest wall invasion or involvement. So here's a case of an invasive cancer with a DCIS component growing up toward the nipple, and we can see that it in fact is growing into the nipple. And here's a case of micropapillary carcinoma with snakeskin calcifications extending from an invasive cancer on the left. And notice that I've had to put multiple fields of view together to show this, but we can see that the calcifications extend all the way into the nipple. In this case, the surgeon has to resect the nipple, and they'll have to do reconstruction for the areola nipple later. But it's important to know whether these DAB or DCIS components actually go into the nipple. And here are invasive lesions without calcifications, but we can see that these are more difficult to evaluate, because when you have an invasive lesion that's subareolar and it actually causes nipple retraction, it creates some technical difficulties. But we can see an enlarged duct going all the way into the nipple in the left upper image, and an enlarged duct going all the way into the nipple in the right upper image, multiple enlarged ducts going into the nipple in the left lower image, and a couple of enlarged ducts going into the nipple in the right lower image. In all these cases, the nipple needs to be resected. Now, here I can see fat necrosis. This is the lumpectomy scar on the left, and I can see there's a recurrent nodule on the right. Where did that recurrent nodule occur? Well, when I rotate radially, I can see that it's actually inside the duct. So missing these DCIS components toward the nipple can lead to recurrences. Now, you can get invasion up Cooper's ligament. The anterior mammary fascia creates a pretty tough border between the subcutaneous fat and the mammary zone. But at the base of each Cooper's ligament, there's a hole in the anterior mammary fascia. In fact, a Cooper's ligament is made of 2 layers of anterior mammary fascia that are loosely attached to each other. So cancer can grow up the base of Cooper's ligament. So if you find a Cooper's ligament in the subcutaneous fat as a hypercoat line and you trace it posteriorly to where it intersects the surface, that's where we find our angles. And when you get a very long growth of Cooper's ligament that the surgeon doesn't know about, and the surgeon does a quote unquote wide excision, the surgeon may get a positive margin where that invaded Cooper's ligament lies. And then later on, we can get a recurrence within Cooper's ligament. And so this case is the actual recurrence from the first case I showed, from this case. So this was 18 months later, and we can see that there's a subcutaneous recurrence, but it's not just subcutaneous. We can actually see that it lies within the Cooper's ligament. So this growth up Cooper's ligament was not recognized and not treated with the way the surgeon would treat that is take an ellipse of skin overlying it, including Cooper's ligament, and that would minimize the chances of recurrence. But in this case, it wasn't recognized, wasn't treated, and this recurrence 18 months later occurred right in that Cooper's ligament. The last thing I want to point out is this pattern of lymphedema. The normal drainage pattern, lymphatics from the breast, is from the lesion up to the subdermal net between the superficial fascia and the skin to the periareolar sappy plexus, and then from there to the axilla. If you get lymphatic invasion and lymphedema, you tend to get edematous or abnormally echogenic ill-defined fat between the lesion and the skin. This usually indicates that there's going to be microscopic tumor in the lymphatics within the skin, and that the surgeon should take an ellipse of skin overlying the lesion. Now, can we core biopsy this and prove that there's lymphatic invasion? Yes, but that doesn't necessarily mean the skin's involved. But in a case like this, I've often taken something like an 18-gauge Achieve needle, and I've done a punch biopsy in the skin overlying the lesion to prove that there was, in fact, lymphatic invasion in the skin. That they should remove an ellipse of skin overlying the lesion. And sure enough, in this particular case, about a year and a half later, she had a skin recurrence. So what can we say? Well, again, I think in the United States, for local regional staging, we feel MR is the best. And for systemic staging, we think PET-CT is the best. But, second look ultrasound is often necessary, even after a positive MR. And ultrasound can be helpful in some patients who can't have MR. And the best time to start staging is right at the time of diagnosis of when you decide you're going to do an ultrasound guided biopsy. So if you convert to whole breast ultrasound, including the axillary lymph nodes at that time, you have your best chance of properly staging from the very beginning. To do this, you're going to have to recognize the difference between non-mass ultrasound findings and mass ultrasound findings, between AABs and DABs, and what the difference between the size and extent is. And I will make a plug here that automated breast ultrasound may facilitate using ultrasound for staging. Everybody just talks about ultrasound, automated breast ultrasound for purposes of screening, but I think it can be very useful for staging. With some of the larger 15-centimeter probes, you may have to develop special techniques in order to adequately show the axillary lymph nodes, but I think it could be very useful. I do want to point out that, we mostly were talking here about how to properly measure a lesion, what does have microscopic tumor in it, what probably doesn't. But the weaknesses of TNM are that understages multifocal and multicentric and diffuse disease, and it also understages when there's combined invasive and DCIS components. And so we told you how to work around through some of these things. And remember that size and extent are different. And I would encourage you to think always, in this case, is size the same as extent? If they're different, how do they differ? What is the extent? What is the size? Extent is going to represent the tumor burden much better than size. And if you want to guide treatment the best, you want to assess what tumor burden is, not just size. The last thing I want to say is that ultrasound staging and MR staging are limited by the imperfections in the way pathologists look at histology today. The gold standard for pathologists is to chop up the specimen into tiny little pieces and mount them on slides that have just 1x1 cover slides. And that really does make it difficult. It's been shown that only 16% of the margins are properly addressed on those slides. And, Laszlo is a big fan of large section, and I've become a fan of 5x7 megacassettes. I think it's much easier for the pathology to confirm what we're seeing on imaging when the pathology is adequate. 1x1 slides are inadequate to demonstrate what we currently see on MR and ultrasound. And part of the reason ultrasound and MR are accused of overstaging is not that they're really overstaging, but that the 1x1 slides are understaging. And part of the reason TNM hasn't been improved is it's still based too much on 1x1 slides and clinical findings and not enough on imaging. Thank you.
Thank you so much, Dr. Tom. I do believe that we have some questions. Just let me check.
Okay.
Yeah. If anyone has a question, I want to remind you that you can use the Q&A option or raise hand if you want to speak. Doctor, we have a question from Ibrahim. It says, if we face a patient with clear margin lumpectomy, invasive cancer, then after 1 month has an axillary suspicious non-palpable lymph node, but seen only at ultrasound, what's the next step and what pyrids given? It's in the chat if you want to see it.
So are you saying that you've ultrasounded the lumpectomy site and that it was clean, but you just have an enlarged lymph node only on ultrasound? Was that the question?
Sahar Ibrahim, can you elaborate, please? Yes. JPCB team, can we give microphone access to Sahar?
Hello, Dr. Starbucks. How are you?
Good.
Can you
Hello.
hear me? Hello.
Yes, I'm hearing you.
I ask you. I face patients with lumpectomy of CA breast. She was do lumpectomy on free margin of CA of malignant cells, but now after 1 month she has seroma, and you follow up ultrasound, discover there is pathological lymph node that has cortical thickening. What do you suggest for this patient? We do FNA or biopsy?
Is the seroma in the axilla or is the seroma in the breast?
Yeah, you have seroma at the site of the surgery, but she has axillary lymph node with some suspicious findings of eccentric cortical thickening.
Is there any evidence that there's infection in the seroma?
No, just only slight skin discoloration, red discoloration of congestion.
Right. Lymph nodes are something that can change very quickly in a matter of 6 to 8 weeks. I almost never do short interval ultrasound follow-ups at less than 6-month intervals. But for lymph nodes, I might give her 6 to 8 weeks to see if they regress at all. If they don't regress, I would core biopsy the most abnormal looking node, but I would give her 6 weeks, I think, just to see if they might just be reactive to the surgery. So what I'm saying is I would do a follow-up ultrasound in 6 weeks. If they're still enlarged in 6 weeks, then I would core biopsy the most abnormal looking node.
Okay, thank you, doctor.
But lymph nodes can react to the surgery. With the fairly large seroma, she certainly could have reactive lymph nodes, and perhaps in a few weeks. She's just 2 months from surgery, you said?
Sahar, are you with us?
Okay, you suggest that we do follow-up or do biopsy from the lymph node?
No, I'm saying I would allow 6 to 8 weeks. I would do a repeat ultrasound of the axilla in 6 to 8 weeks. And if they're still enlarged at that time, then I would core biopsy them then. But I would give her a little bit of time because you can certainly get reactive lymph nodes to surgery. And especially if there's a big seroma, she might be more likely to have reactive lymph nodes. So I'd give her 6 to 8 weeks to see if they regress.
Okay.
And if they don't regress, then I would.
Okay, good. Thank you. Could be a reactionary lymph nodes. Okay, thank you.
Thank you, Sahar. We have another question from Sahar Nasser. Is mammogram reliable for thin female over 50 years old with vigorously dense breast?
I don't think I understood that. I must have missed something. Say that again, please.
Is mammogram reliable for thin female over 50 years old with vigorously dense breast? You can see it at the Q&A option if you want.
I'm still not understanding. Is that a question?
Yeah, the question saying is mammogram reliable for thin female over 50 years old with vigorously dense breast?
Well, yeah, I mean, it'll help diagnose mostly calcifications. I mean, that's an ideal case for whole breast ultrasound, I think.
Nice. JPCB team, can we give microphone access to Jwala? She has a question.
Hello.
Hello.
Yeah, I'm Dr. Jwala from India, and it's been a pleasure listening to you, Dr. Stavros. And my question was that would I be allowed to mention, especially in an AAB plus a DAB disease, to mention the word DAB in my notes, in my ultrasound report? Could I be saying that there are multiple tumors, probably invasive tumors with intervening thickened ducts representing DAB? Can I use that word in my reports?
Do you go to tumor board with your surgeons and your pathologists? It's a matter of training. If you just start using the term and they don't know what you're talking about, it can cause problems. But if you go to tumor board every week and you're talking to your pathologist and your surgeons every week, over a period of time, you can educate them as to what you're talking about. So it's important that everybody have the same language. There are deficiencies in the pathology descriptors. There are deficiencies in the BI-RADS descriptors. There are deficiencies in TNM, but you can't just start slapping people in the face with it. It has to be an interactive educational process where you have a bidirectional discourse. So if you start using terms your pathologists don't understand or your surgeons don't understand, it might cause problems. But the way I did it, I love tumor board. I would spend an hour per case getting tumor board ready so I could present each case in a minute or two. And over a period of a year or a year and a half, I could train the pathologists and the surgeons in how I was thinking. And so it's an educational process. Do I believe that Laszlo Tovar is right? Absolutely. Do I believe that most pathologists believe he's right? No. I think most pathologists resist what he's talking about. But I'm absolutely sure Laszlo's right and pathologists are wrong. But you don't want to create it. You don't want to create World War III.
Thank you so much, Dr. Stavros. It's been a pleasure. Thank you.
Tumor board is the place where you can really get stuff done. But you can't just go there and be inactive or passive. You have to go and you have to be an active participant. And you have to raise questions in the tumor board and you say, this is what I'm thinking. Would you mind rechecking that? I mean, I've done this over and over And you do it in a non-threatening, non-combative way. You do it in a collegial partnership kind of way. So, yeah, there's danger in using terminology that's not standard mainstream, but it's beneficial in the end, but it has to be done carefully and gradually.
Thank you, Doctor. GPCB team, can we give permission to speak to Bagyam Raghavan? Ms. Bagyam.
Thank you very much for this very interesting talk. There was a long back 10, 12 years a paper where they said that the ultrasound never reflects, particularly when tomosynthesis came, they've said that ultrasound never reflects the true size of the lesion. And that was something which you have now, as Tabar has told us, and so have you. Now, one thing that I wanted to know is, we could just write that there is an extent can be possibly like this with the ultrasound. That was one part. Second thing, we are a low resource country. So, by the time we do the biopsy and the VAB, it comes to pretty expensive things. So I just wanted to know how much your results correlated with MR, because MR is still, freely available and it is much cheaper than a VAB.
I have done a lot of second look ultrasound. That's what this talk is based upon. And in the United States, we use primarily MR for staging. But I've done so much second look ultrasound that I've learned how to do staging with ultrasound when I need to. And it's been very valuable. And I think the key is to understand the non-mass findings in ultrasound. People are not, in general, the non-mass ultrasound findings that correspond to DAB or DCIS are under-recognized on ultrasound. They're there. People just aren't used to looking for them. Part of it is that in the United States, we're so dependent on MR, we just don't even worry about ultrasound. We just go ahead and do straight to MR, and then if you want to do your biopsy, they do an MR biopsy. But I hate MR biopsies. I mean, I always prefer to do a second look ultrasound before I do biopsy, and I'd always prefer to do the ultrasound or the biopsy under ultrasound guidance. But I mean, ultrasound is much better than people think, and it's better than MR for everything except grade 3 solid comedo DCIS.
Okay.
So I think ultrasound can beat mammography all day, every day. Can it beat MR? Not very often.
Okay. We have another speaker. Can you give access to Wala Al-Jbour? Ms. Wala? Ms. Wala, can you hear me? Okay, we will have another question from the Q&A until Ms. Wala respond. Doctor, we have a question says, what tools, MRI, ultrasound, mammography, or clinical exam is the best tool to determine the diameter of the lesion?
It depends how good you are at ultrasound. And it depends if you've done a lot of second look ultrasound. In general, I would say MR is the best for determining. And again, I don't like that term size, because size could be maximum diameter, it could be extent. Size and extent are different. I just wish we wouldn't use the term size. When a patient says, "Doctor, how big is my lesion?" there's a lot of different answers. It's not just one answer. But in general, I think MR is the best. But if you've done a lot of second look ultrasound, you can get very good with ultrasound as well.
The last question that we have, it says, when can we depend on mammogram only in the local regional staging?
Why would you want to? Ultrasound is so cheap and easy to do. Why would you want to stage with just mammography? I suppose if you just have calcifications only, maybe you could do that. if they're linear branching calcifications, anything other than linear branching calcifications, or perhaps ILC with architectural distortion. Sometimes the mammogram shows you that it's gigantic. So for an ILC or for linear casting calcifications would be the only times I would say that MR might beat ultrasound. But even in those cases, if I had the probe in my hand, I think I could diagnose as well with ultrasound as mammography. I don't think, in my hands, I don't think ultrasound would ever win. I mean, I don't think mammography would ever win over ultrasound.
Another question, Doctor. Can you do screening with only ultrasound instead of mammograms?
Well, certainly they're trying it in China. And even Wendy Berg has come up with some interesting information. Would it be generally accepted? No. Could you make a strong argument for trying it? Yes. But I think it would have to be a very large study. You know, when you use ultrasound or when you use any modality in a diagnostic mode, you can do a few hundred cases to come up with some statistically significant information. When you're trying to do screening, you know, you're looking at a minimum of 20,000 cases over 10 years. It's a very hard study to do. You know, do I believe it's possible? Yes, I do. Has anybody proven you can do it? No, they haven't. It's a very difficult and expensive, long process to do it. Nobody, I think if it happens anywhere, it'll probably happen in China.
Okay. Another question, Doctor. It says to differentiate the duct extension and branching pattern, what we call the multiple ductal extension from index lesion towards nipple. Is it ductal extension or branching pattern?
I'm sorry, what was that last question? Was it a ductal extension or what?
To differentiate the duct extension and branching pattern, what we call the multiple ductal extension from index lesion towards nipple. Is it ductal extension or branching pattern?
Well, toward the nipple is duct extension, away from the nipple is branch pattern usually. But they're not, those aren't official BI-RADS terms. The official BI-RADS term is associated findings in large ducts with or without calcifications. So I came up with duct extension and branch pattern way back in the 1990s, but that was never adopted by BI-RADS. So BI-RADS just uses the term enlarged ducts. And the enlarged ducts might have internal calcifications or might not have internal calcifications. But for me, I mean, the way I originally defined it, duct extension is toward the nipple, branch pattern is away from the nipple.
Doctor, we have a question. Can we do screening with only ultrasound instead of mammograms?
Yeah, that's the same as another question. And have I done it? Yes, but only with informed consent.
Mm-hmm.
Because again, nobody's ever done the big study proving that you can do that. And again, it's much more difficult to prove a screening study than a diagnostic study. You can get all sorts of statistically significant information about the diagnostic value of a modality, whether it's tomosynthesis or ultrasound or contrast enhanced mammography or PEM or PET, you know, it doesn't matter. In diagnosis, it only takes a few hundred cases to come up with the statistical power you need to prove something works. In screening, you know, you really have to prove that you're saving lives, and it takes probably a minimum of 20,000 people over 10 to 20 years, and nobody's ever proved it. You know, it's such a daunting project. It would be so expensive and so hard to do that it's never been proven. Do I think it's possible? Yeah, I think it's very possible, but it has to be done the right way, and it's never been done the right way.
Do you recommend always to biopsy the additional mass lesions, even if they are adjacent to the index lesion?
Well, it depends how close they are. You know, I was showing those quote unquote stacked tubular carcinomas that almost touch each other. In those cases, I don't think so. I think you could just biopsy one, and then you could use a bracketing wire when you localize it.
Mm-hmm.
But if they're 3 centimeters apart or 4 centimeters apart, then yes, I think I would biopsy both. And again, if they're both positive, I would use bracketing wires for localization.
Okay, we have one more question. Do we need to do ultrasound screening for both ACRD and C, or only D if unremarkable mammograms?
I think you could even do it for B.
Mm-hmm.
The question you have to ask yourself is there a large enough area of dense breast on the mammogram that it could hide a cancer? So even if a person only has dense tissue in the upper outer quadrant and the other 3 quadrants are all fat, it's very, 70% of all cancers occur in the upper outer quadrant. So, even though there's only density in a quarter of the breast, that would be enough that it could hide a cancer. So yes, I think you can do it in B, C, or D. You just have to ask yourself, is there a large enough area of dense tissue that I could, that it could obscure a lesion?
Okay, thank you so much, Doctor. We have plenty of questions, but I'm afraid that we don't have enough time to answer all of them. You can send us the questions and we can forward them to Dr. Tom if you want at any time. Thank you so much, Dr. Tom, for the great session. It was a great pleasure to work with you.
I'm presenting breast cysts on Tuesday, right?
Yeah. The next session with you will be on Tuesday. So see you on Tuesday.
Same time, 6 o'clock your time, noon my time.
Yeah.
Okay. See you Tuesday.
See you Tuesday. Thank you so much. Thank you so much, Doctor. Tomorrow we will have the third session of the series, which will be about basic breast MRI interpretations by Dr. Pam Otto. We will start at 6 p.m. Jordan time as usual. I want to remind you, all of you, that you need to attend all the sessions to get the certification. Thank you so much for your participation and see you tomorrow. Goodbye.